Thank you very much for inviting me, and for inviting me to give this talk, which is based on an editorial that Manfred Blobner from Munich and I published in BJA earlier this year, because things were starting to irritate me about case reports on what were underdosing and overdosing of relaxants and reversal agents. Now, my story starts with Cecil Gray, the first professor of anaesthesia in Liverpool, who in fact was a general practitioner in downtown Liverpool during the Second World War. But amazingly to me, he actually was reading anesthesiology at that time, because this guy was giving anaesthetics in various hospitals and in various homes, actually, whilst he was practicing in primary care. And he read Griffith and Johnson's paper about giving what were called soup songs of D-tubicurarine to weaken the muscles during operations such as hernias and appendicectomies. These were not patients who were necessarily intubated, they weren't certainly ventilated, but Cecil Gray read that paper and he developed what became known as the Liverpool anaesthetic technique, in which, of course, ventilation was completely taken over because of the use of a large dose of tubicurarine. And Cecil very much encouraged hyperventilation, lowering the PaCO2 somewhat. And this became quite popular over the late 40s and into the early 50s. But in those early papers, both from Cecil and from Griffith, there was very little mention of reversal. Griffith and Johnson had said that they had got pyridostigmine on the shelf but never used it, but they only had a series of small number of patients. As Cecil Gray had reported over 1,000 patients, only 3 of whom were reversed. But then, of course, by the early 50s, this famous paper from the East Coast of America, from Boston by Beecher and Todd, which everybody knows about, reported in 45,000 cases that in fact there was an increased mortality post-operatively from those who'd received tubicurarine than those who'd had regional or inhalational anaesthesia. And Cecil Gray never missed a chance to outdo his critics. And as a result, he very rapidly started to postulate that neostigmine should be used in all patients who'd had tubicurarine. And so over the 50s, neostigmine became routine. But over that decade and in the subsequent 60s, reports started to appear of both residual curarization and recurarization. Now, these are, at that point, were clinical reports because, of course, nobody could be monitored at that point from a neuromuscular point of view. But these reports of residual curarization, which was when the patient didn't reverse properly at the end of the operation, or recurarization when they seemed to reparalyze sometime later, started to appear in the press. And these stories are frightening to me, and I'm just going to highlight a few of them throughout this talk. Remember, these were clinical diagnoses. Here's a classic one. It came from Liverpool. Gilbertson was one of Cecil Gray's trainees. And what he highlighted was that these residual and recurarization stories were more common in patients with either acute or chronic renal failure. Not surprisingly, because of course tubicurarine was pretty well completely excreted in the urine. And this saga was of a lady who needed intercurrent laparotomy who had end-stage renal failure. She was given 45 milligrams standard doses of tubicurarine and neostigmine at that time in Liverpool. But she was hypoxic on extubation. And because Gilbertson knew that Gray had neuromuscular monitoring equipment for research purposes, he was actually able to twitch this patient and found that there was no response to a twitch stimulus. So the patient was reintubated and ventilated for 30 hours, by which time, to keep her on the ventilator, she'd had up to 125 milligrams of tubicurarine. And it was 10 hours after the last dose before she could be extubated. And even then she was given more neostigmine. That is typical residual curization. And an example of recurization came from Stanley Fellman from Charing Cross Hospital in London. And I mean, this case sounds fragile, doesn't it? But it was an elective aortic aneurysm lady of only 40 kilos. But she was given succinylcholine and increments of DTC. It sounds as if the operation was a nightmare because it took 8.5 hours. But she had an enormous amount of tuberculin, 67 milligrams. But she was woken up with just a standard dose of neostigmine. But back to the ward, no recovery rooms in 59. And 3 hours later, she was bleeding. So she went back to the ward, from the ward to theatre, a further dose of tuberculin, and she was extubated a second time. But 4 hours later, again back in the ward, she stopped breathing and had to be reintubated. She responded to neostigmine. Now, that's a classic story of recurization. And Cecil Gray knew that there was a problem of residual curization. And there are not many great men who have produced two major contributions to our specialty over 25 years, but Gray did. Because with the physiologists in Liverpool, he realized that what clinicians needed was a clinical monitoring tool that did not require a control value and could be used at the end of surgery to ensure that recovery from neuromuscular block was complete. And so in a series of 3 papers in the BJA in 70 and 71, Ali, Ettinger and Gray described what everybody knows as the train of 4 twitch technique. And as a stress, this was a clinical measurement, but the work was done as a research tool with mechanomyography. Now, mechanomyography is still the gold standard of neuromuscular monitoring, but unfortunately, it's not easy to use in a clinical setting. That was a limitation of this work at the time. But these 3 authors became world famous because of this work, and it's still hugely quoted, this paper. Insisted that the train of 4 ratio, the fourth to the first twitch, needed to be greater than 0.7 before you could safely extubate your patient without the risk of gastric aspiration or muscle weakness. And that recommendation of 0.7 lasted for nearly 30 years, until into the 90s, we started to develop reliable clinical tools, mainly based on acceleromyography, not mechanomyography, that could measure the train of 4 ratio. And of course, in the 80s, in my salad days, atracurium and vecuronium came along, which depended much less on renal excretion than had tuberculin and pancuronium. And this changed the management of patients with either chronic or acute renal dysfunction, like that aortic aneurysm. And so residual curization and recurization became much less common. And I mean, I used to think that it was almost negligent to have a patient who had residual curization and recurized once atracurium came along. But as I highlight in that reference at the bottom there, we were able to show that recovery in chronic renal failure patients given atracurium was the same as in health. And by the 1980s, we were starting to get clinical monitoring tools, such as peripheral nerve stimulators that could visually or tactilely demonstrate the train of 4 ratio, but they could not yet measure the train of 4 ratio. But as we go into the 90s, of course, rocuronium became available, and this was the first non-depolarizer, which was aimed at giving you as rapid an onset of neuromuscular block as had succinylcholine. Remember, this is a very long-acting drug, rocuronium, 30% renal excreted, so not as bad as tuberculin and pancuronium, but not as good as atracurium or vecuronium. Mainly liver metabolism, no active metabolites. This is a long half-life even in health, 17 minutes in health, 90 minutes in chronic renal failure. And as that graph you saw in the last lecture demonstrated, It takes 5 half-lives. I'm more interested in 5 than 3 half-lives, because it takes 5 half-lives for the plasma level to fall to 3% of its peak, when you're not likely to be paralyzed. So by the 1990s, we were starting to get with the Datex relaxograph and then, fortunately, the SX monitor, equipment that could give us a measurement of the train-of-4 ratio. And by the late 1990s, Eriksson, the professor of anaesthesia in Stockholm, was showing that if we used this form of acceleromyography, then a train-of-4 ratio was inadequate. We needed it to be 0.9. And his group demonstrated here in this paper in anesthesiology, on the y-axis, you've got the upper esophageal tension, and on the x-axis, the train-of-4 ratio. For some reason, I never know why, the control values are on the right-hand side. But you can see that certainly with a train-of-4 ratio of 0.7 in the middle, the upper esophageal tension is only half of what it should be at control values on the right. And even when the train-of-4 ratio is 0.9, these were volunteers, doubtless trainees in his anaesthetic department. But you can see that even with a train-of-4 ratio of 0.9, it wasn't as good as control values. So by the turn of the century, it was becoming accepted that if you used acceleromyography to monitor neuromuscular block, that you needed a ratio of 0.9 and not 0.7. And why do we get so excited about this? Well, this work from Murphy in Illinois in 2008 showed here the train-of-4 ratio on the y-axis in patients who had been monitored routinely with acceleromyography on the left side and just conventional. In the States, very, very much peripheral nerve stimulators. They seem to think nerve stimulators cure everything. Now, this is a beautiful box and whisker plot, and it just demonstrates, and this was an observational study. It wasn't randomized, it wasn't controlled. It just looked at patients as they came into the recovery room and saw what degree of residual neuromuscular block they had. And you can see recovery, and those who've been monitored with an acceleromyography were much more likely to have full recovery. And in those patients, these, first of all, are the oxygen saturation. The number of patients who had desaturated to between 90 and 93 in the acceleromyography group was significantly less than in the control value on the right. Those that are desaturated to less than 90%, goodness gracious, I'd be somewhat embarrassed if in my institution there were 19 patients out of something like 200 who had desaturated to this degree, but they were all in the control group, and 11% of them needed airway maneuver, such as raising the chin. So here we have evidence which has been repeatedly substantiated that if you use acceleromyography, that you have less likelihood of immediate post-operative respiratory complications from residual neuromuscular block. And I think everyone would accept that fact. What we have more need to do more work upon, and it's coming through, is whether that lack of complete reversal in the recovery room is substantiated by a higher instance of post-operative pulmonary complications in the days following surgery. And in this secondary analysis we did of the popular study, which was a huge pan-European observational study of residual neuromuscular block. Here on the y-axis, we've got the adjusted risk of a post-operative pulmonary complication. And it's very interesting to me that even in Cecil Gray's 46 paper, the incidence of post-operative pulmonary complications was 12%. So we've not got much better in this respect. But if you look on the x-axis at the cutoff that the patients in the popular study had before they were extubated, what was their train-of-4 ratio? And you can see even at 0.9, the vertical dotted line, The red line is the average risk in this particular study. And you can see that it was a bit better at 0.9, but if you went up to 0.94 or 96, that it was improving even further. So the risk of post-operative pulmonary complications, if your train to 4 ratio was 0.95 before you extubated them, was reduced from, say, just over 10% down at least by 1 or 2%. So this is what we are very interested in at the moment, because there is a correlation, whether it's related to which reversal agent you use or no reversal agent is another lecture. And of course, by 2008, Sugammadex had become available in the UK and large parts of Western Europe and Japan. And of course, to start with, as everybody knew, it was much more expensive than neostigmine. A vial of glycopyrrolate neostigmine at that time was £1. Sugammadex, 2 milligrams per kilo, was of the order of £60, wasn't it? So this put people off, certainly in the UK, where we had to argue for its use, and in many other parts of Europe. In Japan, they seem to be able to use it without impunity. But I think everyone would accept, and soon did, that Sugammadex was much more rapid acting than neostigmine, and it could reverse any degree of neuromuscular block produced by an aminosteroidal agent, as long as the right dose was used. Unlike neostigmine, where everybody would accept you need to establish significant recovery from block before neostigmine is efficacious. And so at that time, in the early noughties, there was this temptation perhaps to try and reduce the dose of Sugammadex because it was so expensive. And Blogner's group in Manfred Brother in Munich did this work, which I think exemplifies the arguments for and against neostigmine and Sugammadex. So on the x-axis, in first instance, we have the dose of neostigmine, given when recovery from block was already established with a train of 4 ratio of 0.5 on the y-axis there, and this measured the time to the train of 4 ratio up to 0.9. And as everybody knows, it takes 10 minutes for neostigmine to have its full effect. And if you look at the 5 microgram per kilogram column, which most people use that dose, you can see a very clear spread of dots around that 10-minute effect of neostigmine to raise the train of 4 ratio to 0.9. Very well established, but the same study also looked at Sugammadex, and here we see on the x-axis 100 or 200 micrograms of Sugammadex. Look at those spots there. If you only use 100 micrograms per kilogram of Sugammadex, you're producing an effect very similar to that of neostigmine when you're reversing moderate block. There's a scatter of dots and they spread up at least to the 10 minutes. It's not till you use 2 milligrams per kilo that you get the advantage of Sugammadex in reversing moderate block within 2 to 5 minutes. And this data is now very well accepted. But I stress again, look at the spread of dots if you use too low a dose of Sugammadex. As time has passed, of course, this problem has solved itself, but only very recently as the patent for Sugammadex has come off, and it's now available generically. But nevertheless, over the last 15 years, there's been lots of reports of recovery, slow recovery, and recurrence of neuromuscular block, even when Sugammadex has been used. Even worse to me, because what's happened is you've all got confidence in Sugammadex, is you've had excessive confidence in controlling the dose of rocuronium that you've been using, to the extent where I describe the use of bucket loads of rocuronium with gay abandon, and it's by no means professional. And this report here, published in A&A in 2007 from Holland, exemplifies what I think is not unusual practice. A bucket load of rocuronium, an intubating dose, fair enough, but then this low dose of Sugammadex, 0.5 milligrams given only 42 minutes later, when the post-tetanic count was only 1. We'd have the next slide, because this graph is in this paper, and I think it beautifully exemplifies several points. So, time after rocuronium on the x-axis, on the left-hand side, recovery of the first twitch only of the train of 4, or just single twitch, which you do obtain with a peripheral nerve stimulator, and on the right-hand side, the train of 4 ratio. And I like looking at this graph because it discriminates very well between T1 and the train of 4 ratio, and the importance of measuring the ratio rather than just a single twitch response. But what happened in this poor patient was, of course, initially you get a apparent recovery from neuromuscular block, but then within minutes, both the T1 and the train of 4 ratio sag. And of course, the train of 4 ratio, much more so than T1, exemplifying how much more useful a monitoring facet it is, before eventually, after another dose of sugammadex, recovery of both variables returned up towards 100%. Imprint that graph on your cortex, frontal cortex. Now, I understand fully that by the end of the pandemic, rocuronium and sugammadex were in routine use in the UK, and I realised it was a hell of a time. I realised that there were many reasons for turning to this approach because of the rapidity of potential extubation. But I ask you whether by the end of the pandemic, enough thought was being given to the doses of these two drugs that you were using, and were you adequately monitoring neuromuscular block when you used large doses of rocuronium in view of that previous slide? And there's been further ghastly stories in the press in the last 18 months on which our editorial was really based. But here we have another story from Holland, not the same institution, I beg to say, but this was a very frail lady, looks BMI of 17.9, with Crohn's disease. Now, of course, whenever you see a patient with Crohn's or ulcerative colitis, you think of their acute phase proteins bombing around their circulation that, of course, mop up neuromuscular blocking drugs. So I realized that such patients can be resistant to neuromuscular blocking drugs. But this patient was having a very complex operation. We all seen them for Crohn's disease, 5 hours, but she was put on an infusion of rocuronium. And very important aspect of this scenario is that she was also given polypharmacy, unnecessary in my view. And one thing I hate about anaesthetic practice is when far too many drugs are thrown in than is necessary. So this poor little lady had both esketamine, clonidine, sufentanil, it seems to me whatever was in the cupboard at the time, including, of course, magnesium, which we all know decreases pre-synaptic acetylcholine release, potentiating neuromuscular block, and even lidocaine can do in high doses. She wasn't very well monitored. She just had a peripheral nerve stimulator, but at the end of surgery, when the train of 4 count was 4, she was given a fairly standard dose of sugammadex. Because the other thing that everybody does now, isn't it, is just use a vial full. Where is the science, you know? And then, of course, she was extubated, but 105 minutes later, back in the ward, not surprisingly, she was in respiratory failure, and a peripheral nerve stimulator could detect no response to the train of 4. And in the ward, she was given sugammadex in a larger dose with a good recovery. Now, it's a bit difficult to know what went on with this case. Was it incomplete reversal or was it recurization? All I know is that I wouldn't want to be particularly proud of having produced this anaesthetic. And even more so is this story of a 3-week-old child coming for pilomyotomy. I mean, this baby could have died. Of that, I've no doubt. And this paper in the BJA actually reviews recurization after sugammadex, as it's called, in small children from the existing literature as well as this case. Now, we have a challenge with neonates and monitoring neuromuscular block. It is difficult, I fully accept, to do a train-of-4 ratio accurately in a small baby. Equipment is improving, undoubtedly. The TOF-scan pediatric adaptations are helpful, but I realise it can be difficult. But they had tried to do qualitative monitoring and not been very successful either. You can do qualitative monitoring in these small children. Now, in error, and we've all made mistakes. I've made mistakes as much as anybody else, but this child was given 8 milligrams of rocuronium. And then, because they felt that they could develop, could detect a post-tetanic count of 2 only 35 minutes later, which I find hard to credit, they were given Sugamadex 4.3 milligrams per kilo. Fortunately, this neonate was still in the recovery area when 50 minutes later it went floppy and blue. This child could have died, and there was no train-of-4 count, and it would have been an anaesthetic death, wouldn't it? Another dose of Sugamadex, and within a minute, recovery was establishing. So these incidents are still occurring. This was only last year. And why are they happening? Well, they're happening for variable doses. One is that I would stress to you that when you use large doses of rocuronium, and from a pharmacokinetic point of view, it takes a large dose to equilibrate between the peripheral, central, and effect compartments. But if you give such large doses, then you cannot expect a small dose of Sugamadex, which will rapidly be excreted in the urine, to encapsulate that huge dose of rocuronium. Favoured, of course, by the fact that rocuronium undergoes much slower hepatic elimination than the renal elimination of Sugamadex. So what is easy to imagine is that as the initial encapsulation of rocuronium by Sugamadex gets exhausted by the high dose of rocuronium that's existing in the body, then you can get what we now refer to as rebound, which is recurrence of neuromuscular block. Don't forget that even from the first descriptions of Sugamadex, before it became clinically available, it takes 3.5 times more molecules of Sugamadex to encapsulate 1 molecule of rocuronium. So the balance is not a 1-to-1 ratio. I fully accept, and it's very topical now, and you've been talking to Dr. Weller earlier, but all human beings, all of us make mistakes, but we can make more effort to improve the obsessional aspect of our clinical technique. Because a lot of these stories I've told you about have been either incorrect labeling or incorrect dilutions or misidentification of drugs, or a bucket full of neuromuscular blocking drug with too small a dose of reversal agent. There is evidence, it's old, that too large a dose of neostigmine can cause recurrence of neuromuscular block. Jimmy Payne did that work in the 80s. It was during halothane anaesthesia, and I know it's fully recognised. I've never been 100% convinced of it in my heart, because that reversal was done while the patient was still anaesthetised with halothane. But nevertheless, the evidence is there. But if you don't monitor quantitatively neuromuscular block, then you are more likely to see these problems. And of course, unless you've monitored, I've got no trouble with failing to reverse residual block if you've monitored it quantitatively, but you've got to monitor it till you've demonstrated full recovery. And you can only do that if you can measure the train-of-4 ratio. I hope I've demonstrated that to you today. The temptation when you're busy, I know, we've all been there. The train-of-4 ratio is approaching 0.9, it's say 0.85, and you think, we're almost there, let's extubate. Be careful, don't do it too soon. And there's lots of evidence that you should use Sugamadex in relation to ideal body weight and should not use Sugamadex according to ideal body weight. You should use it according to the patient's weight. And I pray you avoid polypharmacy whenever you can. So we use the dose of either drugs, any of these drugs, as with anything in our practice that's recommended on the data sheet, adapting it for frailty or age or chronic renal failure as appropriate, especially in small children. I've always been a very keen labeler of syringes. I've always loved doing that. But labeling dilutions is important. And I would say if you're diluting a drug to use in a neonate, then surely it's good practice to check it with somebody else. There's never any indication from using more than 3 times the ED95 of a neuromuscular blocking drug for tracheal intubation. We now have in press, both in the US and in Europe, quantitative neuromuscular monitoring guidelines for you easily to access. But they're fairly simple. A lot of what I've said today is covered there. Always use the correct dose of any reversal agent, and remember that a lot of other drugs, both which you use, such as magnesium, and some of the cytotoxic agents, decrease or impair acetylcholine release presynaptically and can potentiate block. Always use the recommended dose, and I pray develop an obsessional attention to detail. The sky is not the limit for rocuronium dosing. And don't expect a single dose of Sugamadex to reverse a huge amount of rocuronium. I hope I've presented my case sufficiently. Thank you very much, Stephen. Thank you.